Okay, so APRV, airway pressure release ventilation, or bilevel, it's an inverse ratio ventilation strategy. Again, that we flip the IE ratio. So inspiration is bigger than expiration time-wise. So we use this strategy. It's a pressure targeted mode, and here probably the term bilevel and the confusion between this and BiPAP because we use inspiratory pressure and PEEP, right? But instead of calling them their names, we call this P high and this we call P low. Why? I don't know. And it's time cycle. So we give an inspiratory time, of course, but as you can tell, the inspiratory time is bigger than expiratory, so we call it T high, and the expiratory time we call it T low. This is for the expiratory time, and the T high for inspiratory time. And this is an intermittent mandatory ventilations, which means there is a backup rate. Usually we set it 8 to 10, no more, because we want the cycle to be around 6 respiratory cycles to be around 6 seconds. Okay, so and then we allow spontaneous breaths that's not doesn't receive full support. So there's a backup rate, mandatory breaths, that happens where they receive the full support of the inspiratory pressure, the inspiratory time. But the spontaneous breath in between or on top of the backup rate, they can receive either zero support, which means pressure support, or they can receive some pressure support. So there is here, see, a mixture of pressure support ventilation that we may use it for the spontaneous breath. Again, we can set this 0, 5, 10, whatever support we need to add it to these spontaneous breaths. So as you see, there is mandatory breaths, there is spontaneous breath, similar to this IMV. It's just the terms. The main things here is this is an inverse ratio. We want the patient to spend more time in inspiration. The whole goal is to decrease the de-recruitment and improve oxygenation. So this is kind of a rescue therapy when other stuff doesn't work. Again, this is just simple. Things a lot more, there's a lot more details and kind of a bit more complicated. We may do a separate video outside this playlist because this is, I think, a level of pulmonary critical care fellows and intensivist. But if you get to this point, please, you have to have an intensivist and pulmonary critical care on board. And as you see, this is when everything else not working. The FiO2 at maximum, PEEP is optimized, you try to treat an underlying condition, the patient still having hypoxia, so it's a rescue therapy. And mainly we use it in ARDS when there's severe hypoxia and everything else not bringing oxygenation up. Again, you need really a pulmonary critical care medicine to be involved.